So hi, I'm Dr. Julia Garcia Baeza. I'm a clinical assistant professor at the University Complutense of Madrid. And since I came back from the US, I've been very involved with multidisciplinary treatments, especially with what I called orthodontics and aesthetics. I would like to thank Dentsply GAC for inviting me to participate in this webinar to talk about what I love, which is orthodontics and aesthetics, how we improve the life of our patients, not only by giving them a better occlusion, a better function, but also providing them with a beautiful smile. In this 60 minutes webinar, I will start showing you a little bit of the system that I use and what I do and why I do use it. And then I will start talking about multidisciplinary treatments with plenty of different clinical cases. Perfect, so let us start. Since Angle, it is amazing how many different techniques, systems, and philosophies we have gone through the years, during the years. And even more important is all the great things that these people had introduced to our orthodontics field. As Angle, Beck, Tweed in the 1940s, Roth 1980s, Ricketts, Alexanders, and also these last years, Damon with self-ligation brackets. Also, don't forget the MBT technique, McLaughlin, Bennett, Trevisi, and all these people. And after all this, we are coming up with the CCO system. The idea of the CCO system that I use is to put together, to unify all this knowledge with the excellent materials that we have today and also with the newest technology that a lot of different companies can provide us today. This is what we are doing with the CCO system. To me, the first C of CCO is the most important because it stands for complete, and this is what we do, complete clinical orthodontics. So we are not only talking about the flexibility of our wires or how good these brackets are, like in this crowding case, where we fit the wire into every single slot and solve the crowding in an easier way, as you can see here in these occlusal pictures. Or this other case with ectopic canines, as you can see over here. Okay, I'm showing them right now with the pointer. And also, we introduce the wire into the slot of every single bracket. And everything becomes aligned. So it's not only about self-ligation brackets and wires, but also new technologies as CVCTs, mini screws, periodontal problems, like you can see in these two images, like for example, how tipping of the molars, can affect this, the bone or also the gums of our different patients. It's also important to us TMJs, as you can see here, and of course corticotomies. To me, this is the beauty of the CCO system. It's a complete system where everything is important: diagnosis, treatment plan, treatment delivery, and patient management. Why do I use this system? Because regardless of where you start, the end is the same. It is a consistent, reproducible, and efficient system. Before starting talking about orthodontics and aesthetics, my topic, I would like to show you 6 cases, only first and last wires with different malocclusions. Okay, so you can see how consistent this system is. This will be the first case. You can see here we have it's a class 1 molar, class 1 canine. Not very difficult case, deep overbite. And let's see how we start solving it. These are the first wires. You can see now with the brackets in place, the crowding that we have over here. Okay, and little by little, we start finishing the case. These are the last wires. Small details here to finish the case, and the case is done. You can see here all the intraoral pictures once the case is finished. Let's take a look to case number 2 here with an ectopic canine, also class 1 molar, class 1 canine over here, retrocline incisors, okay, deep overbite too. Again, same thing, first wires, last wires over here. We parallel both occlusal planes and the case is done. Okay, here you can see the intraoral pictures of case number 2. Midlines on, we keep the class 1 canine, class 1 molar, but now our upper incisors look nicer. Case number 3 is a class 3, as you can see here, with lower extractions. lower premolars extractions. And the same thing, first wires, we keep working, these are our last wires, okay, and this is the end of the case. Here you can see the intraoral pictures for case number 3. And let's go with case number 4. Same thing. It's a class 1. This is a class 1 case with severe crowding. This is a 4 by extraction case. And the same thing. Upper wires. First wires, last wires, and done with the case. Intraoral pictures. Case number 5 is an open bite, as you can see over here. And again, 4 bites extractions, first wires, last wires, and the case is done. And the intraoral pictures. And the last case that I want to show you over here is a surgical case. It's also a class 3 case in which we are not doing lower extractions. What we are doing over here is a skeletal problem, and what we are doing is an orthodontic surgery. So let's get this patient ready. These are actually the first wires that we are using. Last wires, the surgery is already done, everything is already fixed, and this is the occlusion after the orthodontics and the orthodontic surgery with the CCO system. Intraoral pictures. And those are the 6 cases I wanted to introduce to you before showing you a little bit and talking about multidisciplinary treatment, so you can see a little bit of how consistent and how reproducible and efficient this technique and this system is. So as I said before, regardless of where you start, the end is the same, and this is how it should be. So as I said, it's a consistent, reproducible, and efficient system. Perfect. So after this small introduction, a little bit of what ortho system I use and what do I do in my day-by-day office, I would like to introduce you my topic, my favorite topic. After I came back from the US, I started working actually with some professionals that they're prosthodontists. And it's amazing how can we help each other. And it's amazing also how the communication between professionals and between specialties is how important it is. So this is what I want to show you a little bit today in this 60-minute webinar. So let's talk a little bit about orthodontics and aesthetics. I divided this lecture in 4 different groups. The first group would be facial aesthetics. I mean, we all know that we are able to change faces. This is nothing new that I'm telling you right now. We all know that with orthodontic surgery, we are able to change faces. If we have a class 3, a very protruded mandible, we know that we can change that face. We know that we are able to change lower profiles of our patients. So this is nothing new that I'm telling you. We also know that we are able to change faces and lower facial thirds with orthodontics. We are able to improve them, but we need to know that we are also able to make them worse. And this is also something that I want to talk about in this lecture. I mean, how to be able how not to make them worse. Also, the second group that I will talk about is laterals management. I'm seeing a lot of small laterals nowadays in plenty of adolescents and a lot of my patients in my office. So there's a lot of bolt-on discrepancy, and I would like to show you how I'm managing those problems and those situations. The third group that I would like to talk about is gingival design, okay? For me, that is very important, is talking about proportions of pink structure and also about the white structure. The white structure will be the teeth, and also the pink structure will be the gums. I mean, when you smile, it's not only about having all your teeth aligned, it's also of the amount of gingiva that you are showing when you are projecting that smile. And that is very, very important to me, and I would love to talk a little bit also, I mean, with some clinical cases about gingival design. And then the last group is what I call aesthetic zone. This is, to me, the most interesting group of all of them, is the most multidisciplinary group, and is where I saw how we communicate between specialties, and I saw some tips of making that communication a little bit easier between professionals, which we all know that is sometimes a little bit tough. Okay, so let us start with with the first group. The first group, which is facial aesthetics, as you can see over here. I mean, I'm not going to put any theoretical things over here. What I'm going to do is to show actually cases, clinical cases, so I can make myself understandable through visual pictures and through visual photographs from my own patients. Okay, so let's talk a little bit about Anne. Anne, as you can see over here, she is approximately, she is 28 years old, and as you can see, her face, her frontal pictures. Well, her lower third is a little bit long, okay, and when she smiles, we can see that we don't love that smile, okay. She has a little bit of gingival smile, also this diastema, something is going on over here, okay. So let's see what it is. When we take a look to her profile, okay, right here, this profile is a little bit convex, okay. It's not very, very nice. The projection of the chin is not very nice either. Also, this upper lip is not very, very nice. And also when she smiles over here and we see her profile, the projection of the smile is not as beautiful as it could be. So let's take a look at her intraoral pictures, at her intraoral photographs, okay? And here we can see that she has a diastema, okay? It calls our attention, open bite, tiny open bite over here and on. And when we go to the right and to the left views, we can see that she has a class 3 canine, class 3 molar, and the same thing here. And this patient, she is an orthognathic patient, okay? We need to do orthognathic surgery in this patient. She has a skeletal problem, okay? So we are going to see not only the last pictures of how this face changed and how her profile changed, we are also going to see all the mechanics that we went through with the CCO system, with these orthodontics, okay? Here you can see, as I said before, the gingival smile, okay, and the projection of the smile, which is not the better smile that she can have. Here are the frontal pictures again, and here is the first time we place our brackets and we place our initial wires, okay, very flexible wires, round wires. These are 014 centalloys, okay? So we fit our wire in every single slot and we start leveling and aligning. We keep going, we keep leveling and aligning, we change our wires. We are now on 20 by 20 Bioforce wires. They are also very flexible, okay? And we keep going and we still need to parallel these occlusal planes, okay, before we get here into the surgery. We keep going, okay, she's almost ready for the surgery, and now we are on a stainless steel wires, 19 by 25. Everything is aligned now. The occlusal planes are aligned. So this is right after the surgery. You can see everything here, the sutures, okay, and this is how she comes out, okay. The occlusion is not perfect, and now we need to do the finishing and detailing with this patient. These are our last wires, okay. You can see it over here. You can see that here I did some repositioning. You can see this new bracket over here just to fit our occlusion perfectly. Here you can see the overbite and overjet, okay, and she is ready for taking off the braces. And this is how she looks after the ortho treatment and the orthognathic surgery. You can see here the class 1 canine, okay, canine and molar over here, overbite and overjet, and our midlines, okay, after she went the orthodontic treatment and the orthognathic surgery. Here is her occlusion. Okay, and here is the before and after, okay, of her face. So this first group, as I said, is what we call facial changes, facial aesthetics. So we knew this before. I mean, nothing new. We knew that we are able to change faces with orthognathic surgery. Look at the face now. Look at her lower third. That is looking better. But even better, please look here at the projection of the smile. Look at the difference between the gummy smile right now. No more open bite over here. We decreased the vertical dimension in these patients also, okay? This is the before and after, the occlusion, intraoral pictures. And these are the changes in her profile, okay? We can see the initial picture, as I said before, the upper lip, that we didn't like it very much. This mental labial angle, okay? which is not very accentuated. Also, the projection of the skin is not very, very beautiful. And now, with the orthognathic changes, the projection of the upper lip, the projection of the chin is much nicer, okay? The same when she's smiling. Look at the difference between the projection of the smile over here and look how it looks after the orthognathic surgery and the ortho treatment. Again, before and after. And here is an after her treatment and after 2 years of treatment with the orthognathic surgery. Okay, but as I said, nothing new. I mean, pretty much I'm sure all of you knew this, nothing new. But let's take a look to other case. As I said at the beginning with the introduction, I mean, we also know that with orthodontics, we are able to change the lower third of our patients. We are able to improve that upper lip a lot of times, okay? Plenty of times, actually. But we have to be careful with the new techniques that are coming out nowadays, because we are also able to worsen that profile too and those faces. So let's take a case, one of my cases that I did too, and let's take a look to it very carefully. Okay, so this is Jennifer. As you can see, she's a very pretty girl, very nice girl. Okay, when you see the frontal pictures, she looks very, very nice. Her proportions are pretty good. I mean, nothing very problematic, nothing that calls my attention, okay? When you see her smiling, we are seeing that she has a little bit of crowding over here. Well, more than a little bit is, I mean, a little bit between moderate and severe, okay? You can start seeing the canine over here and this lateral incisor too in a crossbite. But let's keep going. When we see her profile and when we take a look to her profile pictures, we can see that, look here, the upper and the lower lip. Okay, it's not the best profile I've ever seen, but it's not something that really calls my attention. If I'm able to improve it, that would be amazing. But I mean, it's not a bad profile. Okay, we can see here her profile in repose, and also when she smiles, that the projection of her lips are, I mean, is actually pretty nice. Here are her intraoral pictures. You can see the frontal view over here. Now we are starting to realize that she has a crossbite in both sides. She has transverse discrepancy of the maxilla, okay, of the upper jaw, okay. Over here is a skeletal problem, but in the transverse dimension. We can see over here also the overbite and the overjet. She has almost an end on. We are able to see this crowding over here. But the most important part to me is actually right now the transverse problem that we are able to see in this case and how we are going to solve it. So let us start the same thing with the mechanics of our case. As you can see here in this picture, this is the first time I'm placing the brackets, okay? But what I want you to see is that she is wearing an RPE, okay? An RPE to make an expansion, a skeletal expansion. So we first do the expansion on her, and after that we start placing the brackets in the upper and in the lower arch, okay? But first of all, we need to solve that transverse discrepancy on Jennifer. So we keep going, we take off the RPE, and then we keep going with our wires. So our first wires, 014, okay, central wires, very flexible, thermoactivated wires, they are low deflection wires. So we are able to engage them in every single slot. This is the beauty of this technique, okay? We have low friction brackets and also we have low deflection wires over here. We keep going, we just wait, we don't have to do anything else, okay? As you can see, the bite starts closing. And we are now on the next wires and we are still leveling and aligning, okay? Over here, we have 20 by 20 bioforce. They are also thermoactivated wires. Okay, they are square wires, but thermoactivated. They are not stiff yet. And once we get here, I mean, pretty much everybody can finish this case. I mean, maybe a little bit of a stripping in the lower, okay, but the case is pretty much done. I mean, the transverse is corrected, okay. Over here, midlines are on, okay. So we might need to do a little bit of a stripping in the lower, okay, and a little bit of elastics, okay, to settle this occlusion, and the case will be pretty much done, But suddenly, at this point of the treatment, I realized this. I realized this profile. I looked at her when she was leaving and I was talking to her and I said, oh my God, I mean, I'm almost done with the case. I mean, I have it under control. I mean, this is not going to be a problem to me, okay, because I'm pretty much able to close this, to give intercrustation over here, give a good occlusion, a little bit of a stripping and fix it, okay, and I will be pretty much done. But this is what called my attention. So at this point, I started to see this profile. Look at her lips. Look at her upper and lower lip. Look at the projection of them, okay? And look also at the projection of the chin over here. So something was happening. So I decided to take new records at this point of the treatment. What is happening to the face? Frontal pictures, okay? Look over here. Look at the lips, okay? Take a look to the profile. But most important, we are going to take a look to the lateral surf. I don't even need to trace it. This is the lateral surf we took at the very beginning of the treatment. Check out, please, the lips over here. And this is right now, at this point of the treatment. There is a huge difference between both profiles. I mean, I'm making this profile worse, and this is something that I'm doing with my ortho treatments, with my ortho system. This is something that is my fault right now, and now I need to fix it. But how shall I fix it? I mean, the point is that for fixing this profile right now is that I have to do extractions in this case. And I need to tell the parents, okay, you know what? I mean, I told you that your girl was pretty much done, that everything was under control. But you know what? Now I need to take out 4 teeth. This is a problem. This is why I'm telling you the importance of a good diagnosis from the very beginning of the treatment. And that is the beauty of the CCO when I said complete. Because I said at the very beginning is diagnosis, treatment plan, treatment delivery, and patient management. And this is something that we need to take into consideration. So let's take a look. The top pictures are the very beginning, the initial pictures, and the lower row over here is Jennifer right now. Look at her profile. Look at herself. And now, of course, we also traced it to see, I mean, what was the problem and what was going on over here. So at this point, I mean, I decided to tell the parents that I needed to do 4 extractions and that the case wasn't done yet. That it was going to take me pretty much another year or so, okay? Because it's not only about doing the extractions, it's also about closing the spaces and controlling how to close, I mean, controlling that space closure. So here is where we are at this point, and I sent her for the extractions, 4 buys. But please, I didn't do anything. I mean, this is amazing how it looks, but this is how she was. And I did the extractions and she kept the same wires and I didn't do anything. Please take a look to the canines. Take a look to the canines, okay? How they settle down without doing anything, only because they had a space now. Look them now, okay? Take a look to the overbite and overjet, okay, in the front part. Here in the frontal picture, you can see it also very nicely, okay? So we were here, we take the teeth out, and look at this overbite and overjet, how it's settling down. Look at the canines, okay? And I haven't started closing the spaces yet. This is actually the first day I started the space closures with central coils. This is how we do a space closure at the CCO system. And we start closing the spaces. This is the first day we start closing the spaces, and look the profile, how it's changing, okay? This is the initial. This is when we realized that we were doing something wrong, okay? And here is when the extractions are done, but we are not starting with the space closure yet. So we keep going with the case. These are our last wires. All the spaces are closed now, okay? Last wires, our braided wires. Look at the occlusal planes. Everything is parallel, okay? Look at the overbite and overjet. Everything is ready. And we take off our braces. Class 1, class 1. canine and molar, okay, and without 4 bicuspids. But let's take a look to the most important part over here. Let's see how her profile changed. Here is she right now with the 4 extractions and the spaces closed. Let's take a look a little bit closer. So yeah, I could have told the parents that she was doing fantastic, perfect, without distractions, and that I was going to be able to feed all the teeth in her mouth. But that is not the point. I mean, I don't care about lots of techniques that nowadays are saying that, you know what, I can feed all the teeth in the mouth. I don't need extractions. You know what, some cases we do need them. We do need to improve those profiles. Look at the difference between this case and that case, okay? If we are able with these brackets to fit in all the teeth, of course we are. We are able to do that. But we are able to do that, and also we are able to worse that profile because we want to fit all the teeth in the mouth. I mean, I don't think that this is the question nowadays. I mean, the question is not, I mean, if we can do all of our cases without extractions. If we need them, we do them, and that's it. That's it. So look now at the projection of the upper lip, and look also at the projection of the lower lip. Also look at the chin. Look how the vertical dimension changed over here. So these are the, I mean, this is the initial picture. This is the middle of the treatment, okay, when we were, I mean, having those problems. And this is the end of the treatment. And this is Jennifer over here, okay, happy and smiling. So this was the idea of the first group that I wanted to talk, facial aesthetics. So as I said, we already saw Anne, okay, she's an orthodontic and orthognathic surgery treatment. We know perfectly that we are able to change the faces like that. But also I wanted to show a case like Jennifer, because it's a case that sometimes with our ortho treatment, we are not improving the face of our patients. And for me and to me, this is the most important part, to improve the face of our patient, okay? Or at least not to make it worse. Perfect, so let's take a look to the second group actually. The second group is Laterals Management. I call it like that because I wanted to give like a group only for the laterals, because it's amazing the amount of small laterals that I'm seeing nowadays in my patients, not only in adolescents, but also like in teenagers, but also in adult cases, okay? That I leave my canines in class 1, I leave my molars in class 1, and suddenly there is a space, there is a tiny diastema between the laterals and the canines. So how do I manage those cases? Well, let's take a look to Sakia. Sakia is a 29-year-old girl. She's beautiful, African-American girl, a beautiful, beautiful. When we take a look to the intraoral pictures, okay, we don't like them that much. We can see a huge diastema over here. And just with our first view of this picture, we are realizing that the laterals are small, okay, that the proportion of them are not correct. Okay, so this is good because, I mean, from the very beginning we are seeing that something is not perfect and we need to solve it, okay? This is diagnosis from the very beginning of our treatments, very, very important. Okay, so this is her frontal picture. Here she's smiling, okay? We can see that we can fix actually her teeth and she will look even more beautiful than she is. And we can see her over here with a huge smile. And also in this smile, we can also realize these small laterals, okay? So it's something that we know and that we need to fix from the very beginning of the treatment if we are able to do so. Here you can see her profile, beautiful profile, the projections of her lip, of her lips, the upper and the lower is, to me, is just amazing, okay? Very nice, very beautiful. The projection also of the chin, very, very nice, okay? Actually, her cervical angle over here is very, very nice, okay? So no problems with her facial profile. And let's take a look to her intraoral picture. So as I said, over here, we have this big diastema, like a class 2, okay, on the left side, class 2-ish, I will say, a little bit on the right side too, okay. and these small laterals, that is what we are going to talk about in this group. Okay, here is the aesthetic picture where I take only from canine to canine, okay? So we can observe better any anomalies that we can have. And there is something that I want to talk to you about. I'm not sure if you are familiar with this paper and also with this gauge, with this device. This device is called Choose Gauge. Is designed by a doctor in the that was teaching at the NYU program over there. And what it does is not exact, it's not an exact device, but it's very good to realize just by, I mean, in a moment, to realize if the teeth are in a correct proportion or not. So actually, I mean, I use it pretty much in every of my, I mean, in every of my patients at the very beginning before I start to have a view, okay, and to see if if the teeth, if the central incisors, the canines, the laterals are in correct proportions. Okay, you can see here how I use it. Okay, I'm using it now, for example, in the model, and I can see it. Okay, I'm not going to explain how this works, but only because of these different lines, the red, the blue, okay, all these different lines that we have here, we see that the laterals, actually, they are not in a correct proportion, okay, when we compare them to the central incisors. So how do I treat this case, okay? In this case, to me, every time I'm able to build up the laterals, I do so, okay? I prefer to build up the laterals and maintain a good occlusion. Maintain the canines in class 1, the molars and premolars in class 1, and if I have small diastemas, build up those laterals, okay? The problem is in the laterals and not in the rest of the teeth. So why I'm going to start doing stripping in the lower, for example, just to be able to fix those tiny diastemas in the upper. Okay, if the problem is in the lateral incisors, what I do is correct that problem, okay, and solve that problem. In these cases, for example, as you can see actually in this case, in Sakia, in this girl, we have enough space to build up the laterals from the very beginning of my treatment. To me, every time I can do this, I do it. Why? Because I start with the correct proportions of all of my teeth from the very beginning of my treatment. So every time I can do this, I do so. So here you can see actually with the gauge that now the laterals are in the correct position. Okay, and start doing the build-up. Very easy. I mean, I do a WhatsApp. It doesn't have to be something amazing. Of course, after my ortho treatments, it will go to the prosthodontist, and the patient will get like a nicer composites or nicer veneers or whatever. But for the moment, this is more than enough to me. We take a guide over here, a silicone or PVS guide, okay, and what we do, here are the small laterals, what we do is we start building up these laterals with some composite. It's fine if you do it with flowable composite. What I want is just to give the correct proportions. I don't want them to be beautiful right now, so just the correct proportions. So here is here are the build-ups, okay? These teeth are now with the build-ups, and we can see, and we check it again, that we have the correct proportions. And we start with our ortho treatment. Our laterals are built up. We start with our ortho treatment, okay? We keep going, CCO system, the same thing, okay? A straight wire appliance, self-ligation bracket, and low deflection wires. This is the idea. Keep going, and we finish the case, okay? So here you can see the aesthetic pictures. Okay, we are seeing here that we have 7 millimeters and 7 millimeters, okay, the correct proportions. Of course, they're not very beautiful. It's something that I did. I don't do the reconstructions very nicely, actually. But of course, I will send her to the prosthodontist after this, absolutely. And here you see, after her ortho treatment and after we build up her lateral incisors. Here you see, initial and finals, and here you see. Okay, this is a tiny trick or a tiny tip that I'm telling you, like at this gauge, for example. Sometimes it gets very boring to start measuring all the teeth and doing the bolt-on discrepancy. So this is a very easy way and a very visual way to see if our teeth are in a good proportion or not. And actually, also what I'm trying to tell you in this group is that every time I have small laterals and I'm able to build them up from the very beginning of my treatment, I do so. I do so. It's much easier to start with everything in correct proportions that then at the very end start leaving the correct space, like a 0.5 here, more of a diastema or whatever. So this is what I do in my cases. Okay, so I already talked about the facial aesthetics. Also, I talked about the laterals management, how important it is. But what I do want to talk also about is about gingival design, okay? About what I said before, the pink structure and also the white structure, the proportion of them, okay? When you are smiling, the projection of that smile has to be beautiful. And these white and pink proportions and these structure, these white and pink structures have their own proportions, okay? And there is where the beauty of a smile is too. So let's take a look with different cases and different things that happens, okay? So here is Brittany. Brittany is 14 years old, okay? You can see over here at her smiling picture a little bit of crowding, okay, in the upper right, but there is nothing crazy as you can see here in these intraoral pictures. Class 1 canine, class 1 molar, deep bite in this case, you can see here in the lateral pictures, deep bite case, okay? So we start with our orthomechanics. Same thing, these are our first wires. You can see a little bit the crowding that we have here in this side, okay? And we keep going. First wires, keep going, okay? These are already stainless steel wires, 19 by 25. We need the stiffness, okay, over here for improving this overbite. Last wires, and the case is done, okay? Perfect. And here you see, smiling, very nice. Okay, but as I said, this group is called gingival design. So let's talk about the pink and the white structure. Look what is going on in this case, okay? This is the initial picture. We place our brackets. Look right now when everything is starting to level and align, how the gingival margins are starting to get designed, okay? Look up here, look at this canine, look at the lateral incisor, and look how is this changing, okay? And only with our ortho treatment. We keep going, different wires, last wires, and this is the end of the case. Take a look, please, to the gingival margins, how they change from the very beginning, the first picture, to the last picture over here, okay? This is all the sequencing, how the gingival margin change only with our ortho movement. Okay, so we know that this happens sometimes, okay? You can see here the gingival margins, you can see how they change over here. Perfect, we are extruding teeth, and we also know that a lot of times the bone and also the soft tissue comes down when we are doing extrusion, or when we are doing an intrusion, sometimes that gums also come up, okay, and the bone too. We know that, but there are some other cases, like for example, Joe, okay, that we see other things while we are doing our ortho treatment. So let's take a look, okay, to Joe. You can see here, he is 12 years old, super nice kid, super nice kid. You can see also now a little bit of crowding in her, at his smile. You can see the profile over here, this chin, this mentolabial angle, okay? And when we take a look to his intraoral pictures, we can see that he is also a deep bite, okay? He's more severe than Brittany, the case that I just showed you before, okay? But he's also a Brittany. So let's take a look to what happens to the gingival margins here in this case, okay? We start with our brackets and first wires, 014 centaloid. Look here that we are not able even to see the brackets, okay? And we start leveling and aligning the case. We keep going, we are paralleling, okay, here, upper and lower occlusal planes, but take a look to the gums, take a look to the gingival margins, okay? Look at the very beginning, the first time we place the brackets, and look how is this now, okay? A lot of people will say, oh, you know what, that is a bad oral hygiene. And you know what, that is a factor. That is a factor that happens. And that is something that makes our gums, okay, like to be bigger, okay, and also to have like a hyperplasia of the gingiva. But it's not the only factor. It's not bad. Oral hygiene is not the only factor. Actually, Joe, wasn't that bad with the oral hygiene. But sometimes there are forces or there are different movements and everybody reacts in a different way. So a lot of times we do have these problems with our gums and with our gingival margins. At this point, knowing this, okay, we need to tell the parents and they need to know it, that they need to have done a gingivectomy. This is important because of course it's very important, the occlusion over here, as you can see in this lateral view, but it's very important over here, how these incisors look, okay, how this aesthetic zone looks, so the projection of the smile will be nicer. So as you can see over here, okay, this is how the gums were before, and here is after the gingivectomy, okay? A very important tip that I want to tell you is that I always do my gingivectomies when I have my last wires placed. My last wires, I'm only placing them for 4 to 6 weeks, no more than that, 4 to 6 weeks. I do it before taking off the braces because a lot of times when we design the gingival margins with the gingivectomies, there are plenty of times that we see a tiny triangle here, tiny black triangle or a tiny diastema that we want to close, okay? And once the brackets are off, this is impossible to do. We are not able to place the brackets back because the patient will not accept it. So that is why I do always, okay, my gingivectomies at the very end of my treatment, okay, with my last wires, very end, just in case there is something that I need to correct in my finishing and detailing phase, okay? So this is how we finish and we end up the case over here with the gingivectomy done. These are the lateral views. So this is here, Joe, with the hypoplasia. This is here with the gingivectomy, okay? And this is the case, finished and done. And here is Joe. Okay, another case that I want to show you is Daniel, okay? Daniel is 34 years old, okay? And as you can see here at his smile, he has a severe crowding over here. So let's see, and let's talk a little bit also in his case about the pink and the white structure, okay? How we are going to solve this problem too. His profile is pretty much, it's nice, it's good. Upper lip and lower lip are fine. Nothing crazy, nothing that calls our attention. Okay, and here we can see the huge crowding that he has. He has also a necrotic upper incisor, okay, in which we did the endo before starting with our ortho treatment. That is very important. Everything needs to be fixed before we start our ortho treatment. So here's a 4 extraction case. As you can see over here, we took out 4 premolars and we start unraveling the case. First wires, we place the brackets and we start unraveling 014 central wire. And we keep going. Over here, we still are leveling and aligning. Look at the lower occlusal plane. So we are still leveling and aligning, okay? It's a 20 by 20 bioforce wire, very flexible. And at this point, as you can see here, the wires that are shiny, okay, it's a 19 by 25 stainless steel because we do need the stiffness to finish paralleling these occlusal planes over here and to improve them. Okay, so as you can see here in the frontal view, we still have these curvatures over here, and we still need to work on that. Look how they look now, how they are now. Okay, better, much better. And now we are starting, okay, with the details also. Look at the upper incisors. Look at this black triangle that is over here. And this is because of my bracket placement. This happened because I had a wrong bracket placement. That is why I repositioned these brackets over here. Let's take a look right now a little bit closer, okay? Here are my incisors. You can see this black triangle over here and the long axis of both of my upper incisors that they are not correct. So what we do is we reposition those brackets. Take a look now, okay, now they're better. Look at the wire, and this is what we get in 4 weeks. Good, so no more black triangle over here. Now the long axis of our central incisors looks fine, looks perfect. But take a look to the pink structure. So from here, look at the gums up here. Look what happened in 4 weeks. And he doesn't have a bad oral hygiene. He doesn't. But there are other factors, as I said before, that make the gum, grow, a little bit more and make the gums that are not nice anymore. Okay? So at this point, when I'm doing the detailing and the finishing, is when I decided also to start with a gingivectomy before I take off the brackets. Here is when I do the gingivectomy, okay? And this is 7 days post-gingivectomy, okay? And this is how we end up with the case. Please take a look now in the frontal picture how the gingival margins look like right now, okay? Now we have designed those gingival margins. Now the proportion of the teeth are nicer, okay? So let's take a look from the very beginning, okay? Over here, when we had this black triangle, okay, because of a wrong inclination of the upper incisors. Now we reposition the bracket and the inclination looks much better, but the gums, they're not nice anymore. And here is when we are done with the brackets and done with the gingivectomy. Now we have a correct proportion, okay, of white and pink structure. This is the case done, okay, class 1 canine, class 1 molar, of course with 4 extractions, midlines on, and also I always put this picture because I want to show also the correct overbite and the correct overjet, a good anterior guidance. Here are excursive movements, okay, for a dynamic occlusion. And here is Daniel at the end of the case, okay? You can see here the before, okay, and the after. Also, his hair grew a little bit, okay, with our mechanics. No, I'm just kidding, okay? But here you can see also that he had a little bit of a gummy smile, that it got worse during the treatment, and now we have the correct proportions of teeth and gums, okay, of pink and white structure over here, okay? The projection of the smile now is looking much nicer. Good. And then this is, I forgot that I had this over here. Yeah, this is 8 months post-ortho treatment, and he's getting also bleaching of his upper central incisor, okay? And everything is looking much nicer and everything is stable, as you can see over here. So this is the end of Daniel. Perfect, perfect, perfect. And the last thing I want to talk about, okay, the last group that I was telling you at the very beginning that I want to talk about is the aesthetic zone, what I call the aesthetic zone. Actually is, what I call aesthetic zone is the teeth, actually the 6 upper teeth from canine to canine. I call them aesthetic zone because pretty much are the teeth that we see when we are smiling, okay? And they have a lot of importance, okay, when we are talking about multidisciplinary treatment. So as I said before, I love this group. I'm in love with this group. I mean, I love to share my job, and I love the communication between specialties, even though sometimes I know that it's very tough. And I will show you a case to show you a little bit how we talk between the different doctors that we are in our office. And I will talk about this group with this case. So we had a patient, okay, in our office that came like this, okay? She had a trauma, she had an accident, and actually she broke her upper left incisor over here. As you can see, the incisor is not only broken, okay, number 21 is not only broken, it's also apically displaced. So when we see this, there are always several options. Always, there are always several options that you need to discuss about. So, okay, I mean, the first option over here is, okay, I can take number 21 out, okay, and place an implant. That could be an option. But take a look to the gingival margins. Look at the displacement of the gingival margin of number 21. Okay, if I take out this tooth and I place an implant over here, or I mean my implantologist, my surgeon, place an implant over here, okay, in number 21, look at the gingival margins. Whenever this patient smiles, you can see here the smile over here. Okay, look at this gingival margin of number 11. Okay, and look, if I place the implant here and I start with the incisor up here, I mean, the asymmetry is going to be so big that the case is not going to be beautiful at all. So this would be an option, but it's an option that we don't like that much. Another thing that we can do is we can extract that tooth, okay, and we can do regeneration, actually, okay, with soft tissue, with hard tissue. But this is something that is very, very difficult sometimes for surgeons and also for prosthodontics. Why? Because it's very easy to them to gain, to gain thickness, okay? To gain thickness, for example, in this part with connective tissue grafts, for example. But for them, it's very difficult to gain tissue in a vertical way, like down here. So at the end, I mean, that is not going to be very possible. So at this point is when you need to tell them as an orthodontist and tell your other colleagues and tell them what you are able to do with this case. You already know that this tooth is going to be extracted. Perfect. Why not to use it before? Why not to use it, meaning that we are able to extrude this tooth with ortho. We are able to extrude this tooth, and also at the same time we are extruding this tooth, we are able to bring this soft tissue down. We are able to bring soft tissue vertically and actually put both gingival margins at the same level. Okay, this is the idea. Sometimes our surgeons, our prosthodontists, they don't know what we are able to do, so we need to tell them. How we can help them. So we are over here, we place brackets, and take a look now where our gingival margin is. So we build up a little bit of this tooth, okay, over here, and for placing the bracket, for being able to place the bracket and start extruding this tooth, okay. Take a look where is the gingival margin now, okay, of number 11, and where is of number 21, okay. It's even lower. This is what we got with our extrusion, okay. We did, first of all, of course, an endo before starting with extrusion, okay? And over here, we start with extrusion. Look at this tiny gutta percha that is over here, okay? And look now, okay, it helps us like a reference, okay, over here. And we can see that we did pretty much 4 millimeters of extrusion, which is pretty much the amount, okay, of soft tissue that we gain over here. Perfect. So at this point, okay, we are ready. They extract the tooth, we gain the soft tissue, they place the implant, they place a connective tissue graft also for giving some thickness, but the vertical soft tissue is what us as orthodontists we did. I mean, we helped them with that, okay? So they keep going with their treatment. Perfect. You can see here the volume that they gave with the connective tissue graft, but as I said before, okay, the vertical soft tissue, I mean, the amount of soft tissue that we gained vertically, it was because orthodontically we did an extrusion, okay, and we brought down that soft tissue. So here they place a provisional, okay, and they leave the implant over there and they wait, okay. And at this point, I mean, we are almost ready. They are almost ready over here. Okay, same thing, they are starting doing this, okay. They keep going, we keep going with our ortho treatment, okay. And everything is almost ready. Look at the gingival margins, look at the extrusion over here that we did, okay. Now everything looks nice. In this other incisor, they were going to place a veneer, okay. So here was an implant, and in the other incisor, they were going to place a veneer, okay, so they had the best symmetry possible in both central incisors. So we are done with our job. I mean, no more ortho. We did everything we could. I mean, we helped them, okay, and now is time for them to keep working. They take their own models, okay, and they start doing their wax-ups, their things, okay. They start doing provisionals. It's amazing how important are provisionals for the patient, so they can start seeing how it's going to look like, okay, and if they like it or not, and they are able to decide also. These are the provisionals, okay. This is the very beginning of the treatment. These are provisionals, okay. This is acrylic. they keep going, they keep working with the provisionals. Is a very difficult job, actually. Here are the provisionals, but take a look to the gum. Look how healthy it looks, and look at the gingival margins right now. Okay, they take out the color, okay, of the teeth. They place the veneers. They place the crowns of the implant. Okay, look with the provisionals what they did. Okay, I mean what they did at the soft tissues. So the tooth looks like it's coming out of the gum, like it was a real tooth. And this is the end of the treatment. As you can see here, the implant, okay, in the other, in number 11, it has a veneer over here, and this is the end of the treatment. The most important part, and what I want you to look at, is at the gingival margins, please. This is the most important part to me. This is what we did. I mean, without our help as orthodontists, without extruding this tooth and bringing that gingival margin down, this result would have been impossible. So please, communication is the main thing if you want to have excellent results. So pretty much this is it, okay? I love this quote that I say, part art, part science, all orthodontics. I hope you had enjoyed the lecture, and I hope it's been also useful. And please, I mean, anything you need, just let me know and get in touch with me. So thank you very much, and I hope you enjoyed it. Thank you.